Prioritising patient safety, how to minimise risk in fertility treatment. PET are extremely grateful to the Scottish Government for their support of this event to discuss this important topic. Over the last 40 years, fertility treatment has gone from being something that was incredibly experimental to mainstream. I don't seem to be able to attend a Teams or a Zoom meeting without someone posting in chat to me that they're pregnant as a result of IVF. And I was struck by something that the chair of the British Fertility Society said at PET's conference last year. Raj Mithwal said that more people have fertility treatments in the UK than have their appendix out. It really is routine. And fertility treatment can be provided legally in the UK by clinics that are licensed and inspected by the Human Fertilisation and Embryology Authority, the sector's specialist regulator. And treatment at these clinics is, for the most part, extremely safe. And most fertility patients are no more likely to experience problems with health in pregnancy than people who conceive naturally. However, most medical procedures are accompanied by some level of risk, and fertility treatment is no exception. And at this event, we have a team of experts who will explore particular risks associated with aspects of fertility treatment, and they will discuss how best to monitor and minimise these risks. And so the discussion is going to include what steps should be taken before a patient even begins treatment. We're going to discuss ovarian hyperstimulation syndrome, the risks posed by and claims made for immune treatments, the COVID-19 vaccine, and multiple pregnancy and multiple birth. And we have a really stellar lineup of speakers for you this evening. So we have Professor Abha Maheshwari, Dr. Michael Rimmer, Professor Ashley Moffett, Professor Marian Knight, and Rachel Cutting. And Abha is the Clinical Director of the Aberdeen Fertility Centre, and she is Clinical Senior Lecturer in Reproductive Medicine at the University of Aberdeen. And also Abha is the Clinical Lead for the Fertility Scotland National Network.
Thank you for inviting me to speak on this really, really important topic. And as you mentioned, that last 40 years have been spent in IVF, in fine-tuning IVF, and we've been talking about success rate, like live birth rate, how many babies we create. But it is time now that we spend time and effort in minimizing the risks or any risks that treatment poses. By far, the IVF treatment has been very, very safe and successful, and that is why we are now talking about over 10 million babies born, and a lot of treatment cycles get done across the world, and it is constantly increasing. So this is not to scare you that there are risks with IVF, but what we are trying to present is where the risks are, where we have identified where we can minimize the risks, and how we can make it better and safer. So let's look at what IVF risks are. So this is the study we published in 2012 from Aberdeen. So we compared over 650,000 deliveries published across the world and compared them with the spontaneous conception, that is like normal conception versus the IVF conception. And these are only singleton pregnancies, not the multiple births, because we know that multiple births have got more risks. So when you compare with the spontaneous conception and IVF pregnancy singletons, it's 2.5 times increased risk of bleeding in pregnancy, 50% increased risk of high blood pressure, 50% increased risk of needing cesarean section, the similar risk for increase in the diabetes, and there's a slightly increased risk of induction of labor. And these are all maternal risks. I'm not talking about fetal risk because that's a separate talk. So these are all risks to the mother. So when we looked at this data, we questioned ourselves, why are these risks higher? Is it because we are treating somebody who has had difficulty in conceiving? Is it something to do with the treatments that we are doing? Is it because we are growing the embryos in the lab, in culture, we are growing them longer and longer. Now, for 5 days, initially we used to grow them for 2 or 3 days. Are we freezing the embryos or gametes? That's why the risks are there. Or are we using donor gametes, sperm, egg, embryo? Is it because of that? Or is it a combination of factors? So we try to kind of find out the reasons. And there are published data to say that if you conceive on your own, but you have a history of difficulty in conceiving, that you have high risk of high blood pressure in pregnancy, leading to preeclampsia, increased risk of bleeding in pregnancy, increased risk of induction of labor, increased hospital admissions as well. So difficulty in conceiving has some role to play. It's not just IVF alone. We are now treating more and more patients who have got medical complications because medical treatments are so good, and IVF is very safe as well. So if you've got a polycystic ovarian syndrome diagnosed and confirmed, you have a higher risk in pregnancy of gestational diabetes and high blood pressure. If you have Turner syndrome, you've got high risk of high blood pressure, again, leading to preeclampsia, diabetes, and bleeding in pregnancy when you get pregnant. If you have a history of renal transplant, again, a lot of these risks increases, such as high blood pressure, thrombotic events, diabetes, infection. And if you've had previous cancer treatment, even if you have frozen your eggs or sperm beforehand and created embryos, you are just coming to use them, there is evidence that there is increased risk of heart problems, high blood pressure, and diabetes. So your pre-existing condition does make a difference of what risks are there in the pregnancy, whether it's related to IVF or whether it's on your own. What about when we are growing the embryos in culture? And again, I'm concentrating on maternal risks because in 8 minutes, that's all we can talk about. If we grow the embryos to day 5 compared to day 3, then it increases the risk of large babies. And large babies increases the risk of needing for cesarean section, shoulder dystocia, induction of labor. Yes, it does reduces the risk of small babies, but it increases the risk of large babies, and which of the two is lesser evil, we don't know. If you're using frozen embryo transfer instead of fresh, when you compare them with fresh, again, it increases the risk in pregnancy of high blood pressure leading to preeclampsia. It increases the risk of large babies, and again, the risk associated with large babies. So every little bit thing has some effects. Frozen embryo transfer reduces the risk of preterm delivery and reduces the risk of small babies though. However, it increases these risks as well. What about when we are using donor eggs or donor sperms? So when we are using donor egg, it increases the risk of high blood pressure. It increases the risk of preterm delivery because normally with high blood pressure, preeclampsia, you have earlier deliveries. Increase the risk of bleeding in pregnancy or after the pregnancy, and increased risk of cesarean sections. If you're using donor sperm, again, there is evidence that there is an increased risk of high blood pressure in pregnancy. If you're using donor embryos, the evidence is very less, I suppose, because we use very less donor embryos, and evidence will hopefully be accumulating. But if you can combine, because donor embryos have got donor eggs and sperm, definitely the high blood pressure in pregnancy is the common factor. So I would assume that those risks will definitely be increased. What about venous thromboembolism? There is now evidence that the risk of venous thromboembolism is significantly increased in IVF pregnancies as compared to the natural pregnancies. And that is mostly related to ovarian hyperstimulation syndrome that Mike will be speaking about. So they are recommending that if you have got ovarian hyperstimulation, you should use thromboprophylaxis in first trimester, not just stop it when the hyperstimulation risks or hyperstimulation symptoms have subsided. They need to continue. But other IVF patients should be given thromboprophylaxis based on the same risk factors as other pregnant women. Now, we normally don't usually do the risk assessment for everybody undergoing IVF for prophylaxis as we do for every pregnant woman may be something that we may need to consider. And there are actually a good systematic review and the guidelines from Nordic Society and Sweden's. I know that British Fertility Society is working on guidance about thromboprophylaxis, but until they get published, the Swedish Society has a decision regarding thromboprophylaxis, and they have a scoring system similar to what we have got for pregnant women. So we should have that decision during IVF stimulation, and pregnancy should be made by the referring clinician before referral to IVF clinic. And where thromboprophylaxis is required, this should be initiated at the start of stimulation. And again, there are some modifications they're recommending that you can do in frozen embryo transfer to reduce the risk in those who are found to have higher risk. So they are suggesting that we should be identifying these risks very early on and dealing with it beforehand. So what I am suggesting is that we have to individualize each patient, and we have to do a risk assessment very early on to minimize those risks, because IVF is very, very safe treatment, and we know it's here to stay. It has done millions of good things, and as I say, over 10 million babies born. So pre-conception, there are risks. We identify them, whether it's obesity, age. We know that older age has risk. Medical illness I've already spoken about. Is there a family history of any medical disease? If you've got history of difficulty in conceiving, if you've got polycystic ovarian syndrome, we know that ethnicity have impact on the outcomes as well in pregnancy, and whether you've had a history of cancer treatment. So we identify those risks and identify what risk it poses. Then during the treatment, which treatment are we doing? Are we just giving clomiphene tablets? Or we are doing IUI, we are doing IVF, we are doing ICSI? Are we using any of the donor gametes? Are we using then extended culture? Are we freezing the embryos? And the things that are put in red are the modifiable risk factors. So once we identify which risks are there, then we can see where we can modify these treatments, even fine-tune them minutely. Say if somebody's got a high risk of large babies, we should probably consider transferring day 3 embryos, because we know that day 5 embryos have got a higher risk of large babies. We should probably consider using fresh embryo transfer as the first transfer rather than frozen embryo transfer. But again, that has to be put in context with various other things, including success rate, including embryo selection and other things. Where we can modify risk, we modify those risks. Where we can't modify the risks, we liaise with our obstetric colleagues and put things in place so that we can identify these risks earlier, or we can mitigate whichever way we want to mitigate. So it's identifying these risks at every stages and modifying those treatment. So I suggest that we should do preconception assessment for all and risk score them. We provide information to women not just about success rate, but about pregnancy complications as well as the perinatal risks, and let them make the decision as to how and what modifications in treatment happens in conjunction with obviously their clinicians. We are not in the stage that we should say one size fit for all. It's a very individualized treatment and individualized risk assessment. And most important, to identify those risks, we need to collect the data to inform in future much better.
Our next speaker this evening is Dr. Michael Rimmer, Specialist Registrar in Obstetrics and Gynaecology and Clinical Research Trainee Fellow at the University of Edinburgh. He is a member of the Scientific Advisory Committee and the COVID-19 Guidance Committee of the Royal College of Obstetricians and Gynaecologists, and he is former chair of the UK Audit and Research Collaborative in Obstetrics and Gynaecology.
Ovarian hyperstimulation syndrome is a risk of fertility treatment, and it's where the ovaries are stimulated with hormones to cause more eggs to mature, which then can be used in IVF. However, overstimulation from these hormones can cause a condition called ovarian hyperstimulation syndrome. Now, if we look on this image on the right-hand side, we can see some pictures of ovaries, and at the very top you can see what we call follicles. And on the left-hand side we can see we have a normal cycle. And so this is what a woman would experience without any hormonal supplementation. And we can see from the follicles in the top ovary, traditionally one egg would mature, which would then be released and potentially fertilised and will go on to form a pregnancy. However, on the right-hand side, we can see a stimulated cycle. Now, this is when what we would experience when going for ovarian stimulation for fertility treatment, and we can see how at the top there again are lots of follicles, but at the end of that we can see many more mature follicles. And not only are there more follicles that have matured, but we can see that the ovaries got a lot larger. And so I think the important thing to remember throughout this talk is that it's difficult to predict which women will potentially over-respond to the treatment and develop OHSS. So what actually happens during OHSS? Well, as the ovaries and follicles are stimulated, and they can release factors and chemicals into the blood, and this can make the blood vessels leaky. And what that means is fluid from within the blood vessels are able to leak out into various parts of the body, most commonly the abdomen or the tummy. And it's this leaking of fluid from the blood vessels which can cause some of the symptoms associated with OHSS. In addition to the blood leaking out, fluid leaking out of the blood vessels, it can then mean the blood becomes more concentrated. And again, this predisposes for risks such as blood clots, which I'll speak about later. So how can we diagnose ovarian hyperstimulation syndrome? Well, it's what we would call a clinical diagnosis. There isn't a single blood test or scan that you can do to say the first patient has it or the second patient doesn't. It's a constellation of signs and symptoms which the patient will present with, and then the healthcare professional can look at these symptoms and try and figure out if this patient has developed OHSS. What we can do is divide it up into early presentation and a late presentation. So in early OHSS, women typically present within a week of the hormone trigger to make eggs ovulate. So as we saw a few slides ago, when the ovary is larger and you've got lots of mature follicles, you would then give a hormone to begin ovulation. And then a small surgical procedure can be undertaken to collect those eggs. And the hormone that is often used is something called human chorionic gonadotrophin hormone. And in early presentation, this is associated with an excessive ovarian response to when it's being stimulated. But in late presentation, patients will typically present at least 10 to 14 days after ovulation stimulation. Now, when those eggs are collected, they can then be fertilised and transplanted back into the uterus and hopefully become a pregnancy. But with a pregnancy, you also get more HCG. So you've probably heard of HCG, as this is the hormone that's tested for to see if you're pregnant. And so in late OHSS, it's the large amount of HCG that's present which we believe drives OHSS. So when women do develop OHSS, the symptoms can vary from patient to patient. And so in mild OHSS, about 33 in every 100 women will go on to develop it. Whereas in moderate OHSS, only 3 to 6 in every 100 women will go on to develop it. And severe OHSS is the rarest form, and that's only 1 to 2% of women undergoing ovarian stimulation. So what would the patients typically experience if they were to develop mild, moderate or severe OHSS? What is that constellation of symptoms to make that clinical diagnosis? So with mild OHSS, people will often report mild abdominal pain or bloating. Again, that's from the fluid being released from the blood vessels. And if you do a scan of the ovaries, you'd typically see that they are less than 8 centimetres in size. Now, for moderate OHSS, which affects 3 to 6 in every 100 women, you would have increasing abdominal pain and distension from that fluid starting to collect in the abdomen. This fluid can then put some pressure onto the stomach and maybe cause nausea and vomiting. And if you were to undertake an ultrasound scan of the abdomen and the pelvis, you would see that there's fluid within the tummy, and the ovaries now start to look a lot larger, typically 8 to 12 centimetres in size. If we move on to what happens in what we call severe or critical OHSS, it's important to remember that this only happens to 1 to 2% of women undergoing stimulation cycles. And sadly, many of these women will require hospital admission to try and prevent further complications from OHSS occurring. And this is all entirely driven by the fluid loss from the blood vessels, which starts to accumulate within the body. And this can make the signs and symptoms of OHSS much worse than we would see in mild OHSS. So on the right-hand box here, we can see women may develop something called ascites. Now, this isn't a slightly swollen belly. This is a very swollen belly. And that's from a large amount of fluid that's being released from the blood vessels into the abdomen. It can cause a lot of pain and discomfort, and women will present and say, I can barely put my trousers on now, or maybe a pair of jeans that used to fit you only a few weeks ago, now you can't actually fasten them. If this fluid leaks out onto the chest, we would call that hydrothorax. And now, because the fluid is also on the chest, this may also cause some respiratory distress or difficulty in breathing. And in that situation, you may need to consider whether you would try and drain some of the fluid from the abdomen or the chest to try and relieve some of these serious symptoms. Although there's still a lot of fluid in the body, when it's not in the blood vessels, the patient can be quite clinically dehydrated. And so in some situations, you could get oliguria or anuria, which means that there's either a low amount of urine produced or no urine produced at all. And as we saw from a few slides ago, that concentrated blood, because the fluid is leaked out, can lead to something called a venous thromboembolism or blood clots. If they were to occur on the legs, you might have heard them called a deep vein thrombosis or a DVT. And more rarely, but almost also more seriously, if they were to travel to the lungs, that could be a pulmonary embolus. And so many women who develop OHSS are given anticoagulants in order to try and prevent these blood clots developing and exacerbating their already serious symptoms. So are we able to predict who this will happen to? Can we do something to forewarn people that they may start to develop OHSS? Well, it's important to remember that everyone's different. However, some women do have identifiable risk factors which would give us clues if they may go on to develop OHSS. So younger women, or those with a high follicle count in the ovaries, they are at an increased risk of developing OHSS. This is because when you give the hormones to stimulate the follicles to develop, if you have more follicles, if you're younger or have a high follicle count, there's the potential for more eggs to develop in that cycle. If you have polycystic ovaries or have had a previous episode of OHSS, again, these are also risk factors which suggest this patient might then develop subsequent OHSS. The number of oocytes which you retrieve, again, can be an indicator. So the more oocytes you retrieve, that suggests the more eggs that have developed and the more the ovaries respond to that hormonal stimulation. And in late OHSS, if you were to fertilise the egg and then transplant that back into the womb and the lady become pregnant during that cycle, the increase in that hormone we could use, HCG, which is also produced by pregnancy, again, that is another risk factor for this happening. So are we able to stop OHSS? Can we stop this occurring to these women? Well, I think it's all about individualising treatment and finding the right balance, which is having enough eggs to undertake IVF versus reducing the risk of developing it. So I've always divided these up into three aspects of care. The first would be patient-based, patient-focused aspects. So when patients are undergoing their initial assessment for ovarian stimulation, looking at factors such as their age, hormone tests or scans, which you can do to estimate the number of follicles in the ovary, can be used to help you choose which stimulation protocol you might like to use. As we've discussed, the risk factors for developing severe OHSS will be taken into account, but also any of the medical conditions the patients may have and their individual situation. You may then decide to use a different hormonal trigger for ovulation, such as a GnRH antagonist, instead of HCG. The important thing to remember here is these drugs work differently, but they can both trigger ovulation, and it allows the clinician to collect eggs to use in IVF treatment. And finally, when do you transfer the embryo? Women who've had OHSS in the past or appear to have had a large or exaggerated response so far may be advised to hold off an embryo transfer in that cycle, store the eggs, and then once the ovarian stimulation cycle is finished, then consider undergoing an embryo transfer. So we've discussed briefly what OHSS is, why it occurs and some of the symptoms it can cause, what those symptoms are, and some of the small things we can do as physicians to try and prevent it happening in the future.
Our next speaker this evening is Professor Ashley Moffett. Ashley is Emeritus Professor of Reproductive Immunology at the University of Cambridge and an authority on the science and medicine of maternal fetal interactions. And she is leader of Wellcome-funded research into placentation, a reproductive outcome, and disorders of pregnancy.
So I want to talk about very specific risks of ART. And these are some treatments offered in some clinics to suppress the immune system. And this is a list of some of the treatments that are offered. It's not all of them, but just some of them. And they all affect the immune system, apart from intralipid, which I will come back to. And it's quite obvious that in the middle of a pandemic, suppressing the immune system isn't really a good idea. And indeed, the HFEA have given these treatments red in the traffic light system. So I thought I'd actually go backwards and ask, why on earth are these treatments offered if they are potentially exposing women to the risks of immunosuppression? I think we need to go back a long time, 80 years, when this man was asked to explore why skin grafts were rejected during the war. And it was from that an understanding arose of how grafts, skin or kidney grafts, the immune system rejected them was able to distinguish our own self tissues, those of healthy cells or tissues, from those of another individual who was genetically different. And then this resulted in rejection. And then he wrote one essay on this. He never did any experiments, but in this essay pointed out that the mother and the baby were genetically different because, of course, the baby inherits half its genes from the father. And despite this, that they coexist peacefully for 9 months. And later, he never said this himself, but later the mistaken idea arose that maternal immune system could reject the fetus, and this was a cause of pregnancy failure. And I want to stress that there is actually no evidence that this does occur in humans. And there are several reasons why this is a mistaken idea. I think it's perhaps not pointed out often enough that transplantation is an artificial contemporary phenomenon. I mean, no other mammals go around sticking kidneys into each other. But of course, when mammals evolved 100 million years ago, there would have been mechanisms that also evolved that prevented any kind of immune mechanism to prevent rejection. And indeed, we now know many of the mechanisms that operate to prevent any kind of rejection happening. And it's highly unlikely that they would all fail together. There is great redundancy in those systems. Secondly, the fetus itself is never in contact with the mother's immune system. There's always a barrier between the mother and the fetus, which is the placenta. Now, the placenta is made by the fetus. It's the first organ the fetus makes, and it's the largest organ it makes, only to throw it away at delivery. So it does, of course, also express the father's genes. It is different. And it's really the site where the placenta implants into the uterus that we need to focus on, because that is the site where these two tissues from these two individuals come into close contact. And at that site, we find some quite unique immune cells. And if we look here at this, where this is, you can see that the placenta here in blue, which is fetal, and then implanting into the uterus here, and this pink line here is the inner lining of the uterus known as the decidua. And in the decidua, we find very abundant, quite specialized, unique cells only found in the uterus, which unfortunately we called uterine natural killer cells, for actually scientifically for good reasons, but this has been a problem because they do not actually kill. And they certainly don't kill the placenta or the fetus. Now, they are absolutely unique to the uterus, which means that you cannot actually infer anything by taking a blood test, because the blood test, in the blood, there are indeed blood NK cells. And these cells are crucial for killing virally infected cells at the beginning of an infection. but they are quite different than the ones in the uterus. I should say that there are, if you look at almost any parameter in the blood, it will be slightly different in pregnancy because of all the hormones and proteins which shower into the blood from the placenta. But these are secondary effects. They don't have any effect on the outcome of the pregnancy. One of the difficulties in this area has been that we don't really still know what the uterine NK cells do. And I think this has been a problem, and we're obviously still trying to work it out. But all the evidence that we have at the moment does point that they actually, far from being a dangerous, damaging cell, that they actually form a compromise between the implanting placenta and the uterus, so that both of them, mother and baby, survive and thrive. So if you can envisage that you need to draw a boundary between these two individuals, it needs to be a line, and this, the placenta is invading right deeply into the uterus to access all the blood and nutrients it needs, but it cannot go too far. So it needs to go far enough, but not too far. And the NK cells are almost certainly part of this balancing act. So they are not, it's quite unlike the binary outcome of a transplantation rejection response. Now, let me just turn to intralipid, because how did this come into use is interesting. In the 80s, there was one of the treatments that was on offer, supposedly to affect the immune system, was to grind up placentas, these placentas from delivery. And they made these placentas into a white liquid and infused it intravenously. And there was only one trial done for this treatment, and it didn't work, so that was stopped. But the control arm for this trial was intralipid, which is also a white liquid because it's just liquid fat. So it was used as a control. And then rather mysteriously, it became the treatment and not the control. Possibly because it was actually easier just to buy it off the shelf than to go through the great palaver of grinding up placentas. But intralipid is not immunosuppressive. It doesn't affect the immune system in any way. It is just infusing a fat into the circulation. So if I just summarize, I think the risks of these immunosuppressives, particularly in a pandemic, are really serious. There are different risks, slightly different risks for each of the treatments. And in this reference here, for anybody interested, we have put a table describing the risks of each of them in detail. There is no evidence that NK cells are harmful. There's certainly no need to suppress them. They're probably essential for normal pregnancy and for mediating this important balance in the uterus so that the fetus can gain enough nutrients to grow and develop properly, and the mother is protected from over penetration by the placenta. And lastly, the blood tests are not informative in any way.
Marian is Professor of Maternal and Child Population Health and Honorary Consultant in Public Health at the University of Oxford.
So I'm just going to talk through the impacts of COVID-19 in pregnancy, thinking about what evidence we have of the effectiveness and safety of COVID-19 vaccination in pregnancy, but also thinking about COVID-19 vaccination prior to and during assisted reproduction. Most of the data I'm going to present is from the UK Obstetrics Surveillance System, which is the UK national study of hospitalisation with COVID in pregnancy, a little bit from the Embrace UK surveillance of maternal mother and baby deaths. What do we know about what makes women more likely to be admitted to hospital with COVID-19 in pregnancy? Well, of particular relevance when we're thinking about assisted reproduction, we know that similar to the pattern that you see in non-pregnant populations, women who are older are at greater risk of admission to hospital. We know that women who have a higher BMI, who are overweight or obese, are at greater risk of admission to hospital. We know that women from specific ethnic minority groups are also at higher risk of admission to hospital. But when we think about comorbidities, again, in relation to maternal age, we know that women who have diabetes, either type 1, type 2, or gestational diabetes, or indeed hypertension, are also at greater risk. Those risks are also mirrored when we look at those at who is at greatest risk of severe infection. So having been admitted to hospital with COVID in pregnancy, what makes you at risk of severe infection? And you can see that older maternal age doubles your risk of severe infection. Obesity almost trebles your risk. And if you have a pre-existing comorbidity, that's about a 70% increase in risk. And we know that the risk is largely in the late second trimester and third trimester, and that is when the severity of disease. So emphasizes the importance of vaccination either prior to or in earlier pregnancy. So in the first wave of women admitted, about 1 in 4 had moderate to severe infection. That was about 1 in 3 during the Alpha wave, and about 1 in 2 during the Delta wave. And in fact, pregnant women were one of the few populations whose mortality was getting worse during the time of the Delta wave. And there's no doubt that pregnant women are more severely affected compared to non-pregnant people. So again, emphasizing the importance of prevention. In terms of Omicron, we are currently analysing the data. I can say that about 3 times as many pregnant women are being admitted with Omicron than in any of the previous waves. And we are still seeing women going to intensive care, and we are still seeing women dying. It does look as if rates are lower than with Delta variant, but as we've got increased numbers of women affected, we're still seeing numbers of women with severe disease. And just to summarize the outcomes for women, the biggest impact for women is a need for respiratory support, but also a cesarean birth. Between a third and a half of women will have a cesarean birth. The biggest outcome for babies is actually being born preterm, although you can see that sadly 2% of women have had a stillbirth during the Delta period. And we are still seeing some stillbirths in women with severe disease in the Omicron period. But what we do know is that vaccination is highly protective against severe disease. So these are data during the Delta period, and you can see that of women admitted in that period with infection, 96% were unvaccinated, and of those who required intensive care, again, 98% unvaccinated. We are still seeing protection in the case of Omicron. No women who've had 3 doses of vaccine have had severe disease with Omicron. But sadly, women are still continuing to die. And in the Delta period, we also saw babies dying. And recent data from the excellent COVID in pregnancy study from Scotland has actually showed that of all of the babies who died in relation to maternal COVID-19, sadly, all of their mothers were unvaccinated. We know that the outcomes after vaccination during pregnancy are no different or indeed potentially better than if you are unvaccinated. So you can see these are data from the UK Health Security Agency, and very similar data are available from Scotland. you can see that there is no difference in the proportion of stillbirths experienced by women who have been vaccinated compared to those who are unvaccinated. No difference in the proportion of babies who are of low birth weight. And if you can see it amongst women who have been vaccinated, they actually are less likely to have very preterm and extremely preterm births, potentially because of that, the protection from severe COVID-19, which often leads to early birth of the baby. More than 2,000 women in the US or Canada trying to conceive. There was no difference in conception rates between the vaccinated and unvaccinated after adjustment for those health conditions we know that can affect your ability to conceive, and that applies to either vaccinated male or female partners. It was clear that male COVID-19 infection was associated with a short-term decline in fertility, so obviously an important impact of infection. And when looking at COVID vaccination and IVF, again, a large series from a single centre in the US looking at 222 vaccinated patients, 983 unvaccinated patients, showed no difference in the outcomes of ovarian hyperstimulation cycles, and no difference in outcomes after frozen thawed embryo transfers in terms of clinical pregnancy rates and ongoing pregnancy and birth rates. So just to summarise, overall, we know that COVID-19 is not good for pregnant women, and we know that vaccination is highly protective. We've got large amounts of safety data now, and very clear evidence that there's no impact on either fertility or outcomes after IVF.
Now, finally, this evening, we have Rachel Cutting, and Rachel is Director of Compliance and Information at the Human Fertilisation and Embryology Authority.
If we go back a little bit and think about in 2006, it really became evident that the biggest risk to patient and child following fertility treatment was due to high multiple birth rates. And it really became the time to start to address this. Now, the list here about the effects of multiple birth on babies and mothers is well known, and this was very much publicised at the time. But this is actually backed up by the HFEA data that we have produced in the multiple birth report that's been published this week, which shows some of the risks associated with multiple birth here. So you can see that twins are more commonly born preterm, got 91% of singleton at term compared to 39% at term for a twin pregnancy. And again, if we look at the weight of babies that have been born, 92% of singleton pregnancies are born at ideal weight compared to 44% of those in a twin pregnancy. So if we go back again to think what was done quite a few years ago now, in 2007, there was, following the publication of the One at a Time report, which was written by Professor Peter Brodie, a stakeholder group was set up. And this really did encompass a wide range of societies within the UK to really try and tackle the problem of multiple births. And the aims of this group was to produce professional body guidelines, develop a website called the One at a Time website for both patients and clinic staff, produce patient information, and we organised a series of workshops around the UK for IVF centre staff, which was aimed to share good practice. And there was also recommendations that the group made to the HFEA. So as I said, this is going back quite a few years. The guidance was produced in 2008. So where we are now, and I think this is really striking that's been published this week in the report. You know, at 2009, we're actually under 6% multiple birth, which is a huge achievement. And if we look across the UK, the lowest rates are seen in Scotland at 4.7% multiple births. But when we delve into the data a little bit more deeper, there's more things that we can learn. So you can see here, comparing 2007 to 2019, the multiple birth rates decreased for all ages, decreasing the most in the youngest and oldest patients. So you can see the marked difference between the 18 to 35s and the over 44s, for example. But this graph particularly pleases me. This shows the change in practice of the amount of single embryo transfer that has been used. And it really is remarkable now to see how it has been increased and utilised now in clinical practice. So you can see, for patients under the age of 35, over 80% of those patients are now having single embryo transfer. But as I said, there are risks that remain. And using this report that we've looked at, we think there can be some further improvements made. This graph shows that when patients, especially the younger patients, still have a multiple birth when 2 embryos are transferred. And in this graph, if you think this data is from 2015 to 2019, most centres now are using their multiple birth minimisation strategy to select patients to have ESET. So these patients that are having double embryo transfer in the last few years are probably patients that have a poorer embryo quality or have had multiple cycles, but it shows there is still a risk there with a 30 to 35% chance of a multiple pregnancy in younger patients when double embryos are transferred. And if these are poorer quality embryos, I think it really does reflect that clinics perhaps need to address their single embryo transfers to check in these groups what the actual multiple birth rate is. It's about auditing the data in the clinic carefully. And this graph shows that when 2 embryos are replaced when they're created with donor eggs, the risk of multiple pregnancy is high, certainly reminding us that where donor eggs are used, ESET should be used as well. In our report, we also found that patients of Black ethnicities has a slightly higher multiple birth rate than other groups of patients. And younger, privately funded patients had a higher multiple birth rate than those in the NHS, with the pattern continuing in all ages. So what are our key messages that we want to get across? It's been brilliant. The sector has responded amazingly in the UK and multiple births have decreased. Birth rates haven't fallen, but can the risk be further reduced? So the HFEA remain committed to reducing the risks due to mobility births. Of course, clinics still need to play their part as well, but the HFEA will continue to monitor clinics' multiple birth rates on inspection and encourage clinics to review their minimisation strategies, particularly into what we've learned in this report, for example, patients from ethnic minority groups and use of donor eggs. We will continue to work with clinics that are non-compliant with the 10% target and monitor the multiple rates nationally. We produce an annual fertility trends report, which we always highlight the multiple birth rate. We've also just completed a national patient survey, and part of the survey did include questions on multiple birth decision making. We've asked patients whether they felt informed, whether they felt they were told the risks of a multiple pregnancy, and how they came to reach the decision to have a single or double embryo transfer. And we will be reporting on that probably in May 22. And of course, we set out with this back in 2007. We will continue to encourage those who commission fertility services to review the funding provision in line with NICE recommendations and consider whether restrictions in NHS funding does have an adverse impact on multiple birth.
How many vaccinated women have still caught COVID and still ended up in
the data I presented, there were 1,436 women admitted, and 53 of those women had had a prior vaccination. 37 had had 1 dose and 16 had had 2 doses. And when you look at the women who were admitted to intensive care from that group, there were 235 women admitted to intensive care, and only 5 of those women had had a prior vaccination, and only 1 had had 2 doses of prior vaccination, which shows a very strong protective effect against severe disease.
Thanks very much for that really precise answer. And reassuring answer about having, the full protection from the vaccine and making sure that you're up to date. Who knows how many boosters we'll be having down the line. So the next question that I'm going to take is from Daniel Bryson, and his question is for Abha. So he says, you identified frozen embryo transfer as a particular risk for hypertension and large babies, but aren't the risks of fresh transfer greater, if anything? On average, frozen transfer babies are quite close in size to naturally conceived babies, whereas fresh transfer babies are much more likely to be born small, as you mentioned. But small fresh transfer babies also show catch-up growth into childhood, both of which are risk factors for cardiometabolic disease in later life. So how do we balance this risk to fresh babies, or I suppose fresh embryo transfer babies, against the smaller chance of being born large from frozen transfer? So it's quite a long question from Daniel there for you, Abha. So.
Thank you, Daniel. So the talk I was giving was on minimizing the complications for mother. And I appreciate there are risks associated with fresh embryo transfer. There are risks associated with frozen embryo transfer. So both have got risk associated with them. What I was trying to mention is that if you individualize those risks right from the very beginning of patient own factors in preconception stage, then look at the treatments and find out how you can minimize the risk. So there is definite increased risk of large babies, and it's not just close to normality, it's large for gestational age babies, which are defined as more than 90th percentile or more than 2 standard deviation, even when you compare with spontaneous conception for frozen embryo transfer. We know that there is a higher risk of preeclampsia as well, which is obviously leads to severe complications in pregnancy. So if there are already existing risks, say if you're treating a diabetic patient who has a risk of large babies, then again, you are increasing those risks. Now, I don't know, and I don't think data is there right now to say whether these risks get added or they get multiplied. So it's all about individualization. It's not that for everybody frozen is better or fresh is better. It's about individualization based on those risks, and both maternal as well as perinatal risks along with success rate need to be considered, and then an individualized decision need to be made with the clinician and with the couples as to what is better.
Is Scotland going to review its policy of deferring fertility treatment for unvaccinated women? And if so, when? So as the clinical lead in Scotland, Abha, perhaps we'll go to you for that one.
Thank you very much for the question. So just to kind of take a step back and remind that why this decision was taken to temporarily defer fertility treatment for women who were not fully vaccinated. This was taken way back in December in response to the clinical concerns raised by the lead clinicians of the assisted conception units, and they were based on patient safety. I mean, this is the session we are talking about patient safety. So it is about optimizing everything prior to the treatment. We know, and you've listened to Marian, that there is an increased incidence of illness, hospitalizations, poor outcomes from COVID for unvaccinated pregnant women and their babies. At that point, there was a steep rise in the number of COVID-19 cases, and we didn't know the impact of Omicron variant on pregnant women. And the data particularly on Omicron is still not there, but we know that Omicron itself is slightly milder. We have been reviewing the evidence as well as the prevailing level of COVID-19 during January, and will continue to do so in February to determine when the treatment of unvaccinated women can commence. But just to reassure you that most women who are coming for fertility treatment have been vaccinated. We are aware that COVID-19 vaccines are absolutely safe. There is an excellent leaflet by British Fertility Society, and Marian has presented the data as well. And it is strongly recommended that everybody who's undergoing fertility treatment should have vaccinated. And JCVI has put pregnant women at a high risk group as well. So the decision of deferral affect very, very small proportion of women, which is a tiny number. And we are reviewing the evidence, and we will make the decision based on the evidence.
Great, thanks very much. Now I know that both Mike and Marian have obviously got expertise on the vaccine, so I didn't know whether they wanted to add in something on this one in response.
Yeah, I was just going to come in and echo very much what Abha has just said. You know, we know that COVID-19 causes about 1 in 20 women, if you get COVID-19, about 1 in 5 women with symptomatic COVID-19 will have a preterm baby. And we know that sadly there will be some of those babies will die, and some babies will be stillborn. If you've got a really precious pregnancy as a result of fertility treatment, you want to do everything you can to make sure that you're not going to put that pregnancy at risk. So actually what we should be saying to women is not, when will Scotland change the policy? It's it's what information do you need for me to help you make the decision about vaccination.
Sarah, if I can also add that we are all fertility centers are providing counseling to those who want to discuss the vaccination, and also the fact that those who have had their treatment deferred, that time is going to be added on back to them, so they won't lose out on NHS funding. We've also writing letters to vaccinator as soon as we have got details of vaccinator that second dose can be given earlier, like in 4 weeks rather than waiting for 8 weeks. So this is the way we are supporting anybody who is unvaccinated. And so just let your clinics know, and they will be able to provide all the support.
Great, that's great. There's a strategy there to try and streamline the process for those women who understandably are sort of anxious and frustrated and want to, want to get on with their treatment, because obviously the biological clock never stops ticking, and that's always a concern for patients. Even if it's only a short delay, it's quite difficult sometimes for them to sort of reconcile. Okay, we'll move on then to Laura Pastorelli with a question for Rachel. Do you feel the CCGs also have a role to play in funding more cycles of treatment? You mentioned self-funded patients have higher rates of multiple births. This is likely to be driven by the desire to get pregnant and the impression that double embryo transfer will increase chances of pregnancy. Cumulative pregnancy rates are good with multiple rounds of elective single embryo transfer, but especially due to delays with COVID, patients feel that time is not on their side. Funding, do you think, and this is a question that I was going to ask actually, Rachel, but it's a slightly different way, I suppose. Do you think that Scotland has the lowest rate of multiple births in the UK because they have the best funding? Over to you, Rachel.
When we first started the One at a Time campaign all those years ago, we looked at the research that was available at the time, and Belgium had adopted single embryo transfer and looked at the health economics of this. And because of the reduction in cost of the costs of maternal care and the care for babies, they funded more IVF cycles, and it showed that the uptake of single embryo transfer was certainly easier. And having been an embryologist working in the sector before I joined the HFEA, when a patient's got 2 or 3 cycles of funding, it is a lot easier to persuade a patient to have a single embryo transfer than a double embryo transfer, and especially if the patient has to find thousands of pounds to pay for a cycle, that will of course may influence a decision, and that's when you need a careful discussion with your clinician and the embryologist. Abha probably will be able to come in and explain the situation in Scotland, but certainly we have seen in this latest report a lower rate of lower rate of multiple pregnancies in Scotland at 4.7%. But interestingly, it wasn't, if you look at overall at the averages, Scotland has the highest live birth rate, and it also has slightly, very only slightly, the highest age group, average age as well. So it's not tied, like I said earlier, to a decrease in live birth rate. But Abha, how does it work with, is it 3 cycles for most patients then?
Yeah, so Scotland has got highest level of funding, which we are very, very proud of, and thanks to Scottish Government for funding such a generous IVF and a full commitment of NICE guidelines. So we have up to 3 cycles funded, and each cycle include fresh and all frozen embryos created from that stimulation. So it's not just the number of transfers. So full 3 cycles are funded where suitable. Obviously, before every cycle, we suitably assess patients for their entitlement.
Yeah, our research and intelligence team at the HFEA do produce some fantastic reports, and the Fertility Trends report has shown an increase in embryo freezing, which I think is, again, encouraging, and looking at that increase in single embryo transfer, that ties in, and that's when we really need to be thinking about the cumulative rate with single embryo transfer, not just an event to an embryo transfer.
How many clinics are currently practicing minimal stimulation to minimise risks of OHSS?
It's important to remember that each protocol is based on the discussion between the patients and the physician for what's right for them based on their history. And so I wouldn't say that every unit will automatically go to minimal stimulation protocols straight away, even though it may reduce OHSS. But in terms of the proportion of units which are offering it, I'm afraid I can't offer a direct answer to that. I know Professor Abha Maheshwari might be able to answer this a little bit better. She looks after Scotland, but I'm not able to answer that, sorry.
Okay, Abha, do you know that for Scotland?
We don't overstimulate patients, and the risk of ovarian hyperstimulation is very low. So we use various ovarian reserve markers to determine which stimulation to use. And I'm not really aware of anybody using more than what ESHRE guidelines recommend for stimulation, which is 300 international units per day.
Thanks very much, Abha. I wanted to sort of come in with a question for Mike, actually, as to, why is it so hard to predict OHSS? And sort of with your crystal ball, do you think that we will get to a point where there will be some sort of diagnostic test for OHSS? And we talk about personal medicine in every area of medicine, and I know that that's different from personalized care, and doctors treat people as people, but do you think we should be working towards, or we could be working towards, sort of an individualized sort of, take a blood sample, it's whether it's looking at some sort of particular gene profile or whatever it is, and that would then inform the drug regime? Sorry, that's quite a long-winded question for you. There you go, Mike.
I certainly think as we are improving with data collection for people undergoing fertility treatment, potentially the use of big data to look at large patient groups across the world, I think we may be able to pinpoint down further risk factors for developing OHSS than we currently have now. It's important to remember years and years ago we would struggle to predict it, and it's only from analysing big data sets collected, which we are quite good at in Scotland, that we've been able to really pick out, so what are the increased risk factors for these people. In terms of a specific blood test, I guess it's possible one day. It's important to remember that with new diagnostic technology and therapeutics, what we can look at in the blood and the quality of scanning, as we've seen, as that's developed in OBS and Gynae, one day we may identify a potential new biomarker which could predict severe OHSS, but I think that will require quite a lot of funding, and again, very willing patients, which the IVF patients often are. And it'd be wonderful to achieve that, especially if you could be used to almost create a prediction modelling system to maybe identify which patients may be increased risk. But at the moment, I don't think we're quite there yet to be able to have that silver bullet to say yes or no, you won't develop it at this stage.
Thanks very much for that. So the next question we've got this evening is from Nawal Al Abdullah, and they want to know, has there been a study that's shown that those who were vaccinated after infection with COVID had a decline in their fertility? So we'll perhaps go to Marian for that one first.
So I'm not aware of any studies looking at vaccination after COVID that have shown any reduction in fertility. We do know that COVID itself, as I presented, causes a temporary reduction in fertility in the male partner. Didn't appear to have that effect in the female partner, but no studies have shown any impact on fertility.
Great, that's very reassuring news. Did you want to come in, Mike? Sorry.
I can come in briefly as a side step to that. It's currently unpublished, but I'm undertaking a systematic review looking at miscarriage and rates in women who've received a COVID-19 vaccination. We've pulled in a lot of data, so the pregnant women who were accidentally included in the initial RCTs who became pregnant, and some data registry studies. We've got over 30,000 patients, and there's absolutely no increase in the rate of miscarriage or reduction in live birth. And the prevalence of miscarriage in the unvaccinated or placebo controls was the same as the vaccinated cohort. And the recent series in the Lancet, looking at miscarriage, the rate of miscarriage was, I think it was 1.5% difference between the review that we're currently undertaking, hope to publish soon, and the published instance of miscarriage. I think this is quite reassuring, because this is all the COVID vaccines that we looked at. We looked at any dose combination, so the few who were accidentally included in the RCTs and may have only received one dose, we included them, and we also included people who were triple dosed or boosted as well, and we can't find any increase in the rate of miscarriage, which I think a lot of women will be very concerned about, especially in this meeting as well. So we're going to conclude that you should take your vaccine if it's offered.
Great, thanks for adding that important message as well, because I think there is a lot of anxiety. We can't, and so I think the more data we have and the more research that's being done is really encouraging. And there's a comment actually from Gulam, who asked a question earlier, saying there are longitudinal reports which show damage to sperm parameters post-infection 3 months later, but there's limited good quality post-vaccine data at the moment. So we'll watch that space on that one. So I wanted to hop to a question down the list from Melanie Davis, who says she's very proud of contributing to the multiple births work that Rachel referred to. But she says, with the forthcoming update of the NICE fertility guideline, what changes would the panel like to see to improve ART safety? So Ashley, you've not had a question yet, so I'm going to go to you first on this one to see what you'd like to see in there.
Well, I think I am reassured that the HFEA are taking steps to for the clinics to stop using these immunosuppressive therapies. That there is some concern that might push it a little bit underground, because I've noticed some of the websites that are still saying that we'll discuss this with you in the clinic. We can do these tests, we can offer these treatments, but they do say now that they are have a red traffic light and are not advised. So I think that is a slight concern, but it is welcome change, because it seems to have been a very long time that they've been continued to be used. Yeah.
So hopefully when NICE look at the guideline, because they have put, I think, add-ons in the scope of the guideline, they will look at it for immunology and decide that they're not going to include it, perhaps, is what one may hope for. So let's go to you next, Mike. What would you like to see in there or not?
I think it's important that we're very transparent with the data collection we have. Currently, the onus is on clinics to report complications like OHSS and how it's termed. Not that I'm implying that the data is inaccurate, but it's very difficult when it's only coming from one source to be entirely certain of that accuracy. So I'd quite like to see centralised reporting as opposed to just from clinics. And I appreciate that's very easy for me to say, and it's probably quite expensive to set up, but I do think as we increase reporting accuracy and data collection, we might be able to improve the safety of IVF.
Abha.
Yeah, I would like to see preconception optimization to be included, and I think it is included in the scope for the Minimise guidelines. So, yeah, I mean, if we get it, as I said, right first time and do whatever we can do to optimize things beforehand, such as BMI, smoking, wherever, like MMR vaccine and other things. So it's very, very important that diabetes control, for example, those who are diabetic, to reduce any risks, because it takes a lot for patients to undergo these treatments. And what we want to give at the end of it is not just the positive pregnancy test, but a healthy mother and a healthy baby and healthy families. And the only way that can happen is if we optimize everything before starting the treatment or before committing to any treatments.
And Marian, given your work across the piece on this, is there anything that you'd like to see?
Yeah, no, I was going to come in and echo both of those points. I mean, many of you will know one of my other roles is as leading the confidential inquiries into maternal deaths in pregnancy. And it's tragic when we review the care of women who have died, who have very clear risk factors for cardiac disease prior to assisted reproduction, and nobody has either recognised those risks and talked through reduction of those risks before undergoing assisted reproductive treatment. So I can't emphasise more strongly what Abha just said. You know, what we can do before treatment is much better than anything that we could do once women are already pregnant, and at the end of the day that will help get a healthy mum and a healthy baby, even though it may mean for women waiting a little bit longer before they have their treatment.
Yes, certainly we had Kathy Nelson PSC speaking at an event a while ago, saying, you know, that what is actually a blood pressure dip, a test rather, and a urine dip would be incredibly helpful in, you know, although they're rare, they're incredibly, you know, they could, some of these could be avoidable with some actually, you know, quite basic early interventions. So yes, so let's hope that makes it. Rachel, did you want to add anything?
I mean, strengthening the advice and guidance of the use of add-ons would be very helpful, especially for those that are being used with limited or no evidence. But I think also in the scope there needs to be guidance to ensure equality of access to fertility treatments for everyone.